Thanks very much. I'm really a spokesperson on behalf of Tani Fassi, who's my boss, who's the sole protagonist for ECT at Gateshead. So she set the service up and delivers it, and I work for her, and I'm really presenting her work. So really I'm just presenting our cases in the first year, a bit what's come through the door, what we've learnt, and it's really just the case presentation. It's just a sign of things to come, what we've treated. So Gateshead itself is a breast screening unit. It's in the northeast of England. And the ECT service comprises of the screening areas, so Sunderland, Durham and Gateshead, but also Northumberland, Newcastle, just north of the River Tyne. And I know Tani's had a lot of support from Mr. Muir at James Cook, who's one of the plastic surgeons there, in setting this up for advice, and she'd want me to mention him. Okay, so in about the last year or so, treated 8 patients. 4 of these patients have had 2 procedures. The majority have actually had intratumoral bleomycin. Only a few have had intravenous. That's partly due to our anaesthetist, who's quite risk averse, and she almost has the final say on whether we give IV bleomycin. Her concerns are generally obviously pulmonary, and the North East has quite a high incidence of chest disease anyway, and my impression is that anaesthetically they have to reduce the oxygen levels, and in patients with pre-existing lung disease that's a big concern for her. So average age about 72. Follow-up's very variable amongst the cohort, obviously depending on what other palliative treatment they're having. It's not really uniform amongst any of the patients. A real mixed bag of comorbidities amongst the patients. So first case, 63-year-old lady. This is more or less chronologically, I think. So 63-year-old triple negative disease. She had initial surgery, breast conserving surgery and a clearance, and she had adjuvant treatment. So she had 2 cycles of ECT in December of 15 and March 16. So as you can see from the photo on the left, it's a pre-procedure photo of nodules just over the chest and onto the right breast, onto the abdomen as well. And then top right, obviously 2 weeks first procedure, so that kind of Ishar scab, and then 12 weeks post-procedure, quite a good result. Unfortunately, this lady had progression of visceral metastases and then was recommenced on systemic treatment further. So the second case, 59-year-old lady, she actually had a distant disease at presentation, estrogen receptor positive. She had palliative treatment and then developed skin metastasis on her abdomen. And then she had ECT in December last year, 2015, and had a good response. So it's quite obviously, I don't have a wider picture to show you at site. That's pre-procedure and post 6 months later. We're actually finding a lot of our patients don't have much in the way of post-operative pain, and most of it's managed with paracetamol. So third case, 75-year-old, triple negative bilateral disease. Initially has had surgery, developed skin metastases, had 2 lots of electrochemo with intratumoral bleomycin. That was interspersed with some chemotherapy due to new nodules being developed. So you can see, obviously, the skin involvement is quite extensive, and just the more nodular disease at the sternum was treated, because that's where she's most symptomatic. So that's a pre-procedure. Already it's kind of de-epithelialized, and then 2 weeks post-procedure, not much difference, but she did have a relatively good result long term. And then coming around the back, she had further nodularity, which was treated. Obviously, the other bits of skin weren't treated. Again, this is one of our earlier cases. And then the bottom 2 photos are of 2 weeks post-procedure. Sorry that some of the pictures aren't massively in focus. It's all done on an iPad. There's no medical photography at the QE. She had minimal pain, but a lot of itch, which is what some of them we found have complained of. And we actually found, you've seen on other photos today, there's quite a lot of exudate on some of them and a lot of like tissue leak, which does settle down in time. Case 4, 75-year-old, had previous mastectomy and adjuvant treatment after that, then presented about 4 years later with skin mets. She had 2 lots of ECT. So, photo on the left is pre-procedure, so you can see over a mastectomy scar and up towards the neck and clavicle, and then there's 2 weeks post, so all that area is treated. And then that's again the same picture again on the left, and then that's about 3 months post-procedure. So she had a relatively good result again. Nodules on her neck on the left, and then 2 weeks post-procedure, quite a lot of erythema. And then this was her second lot. You can see there's kind of telangiectasia and a bit of scarring from the previous therapy and the new nodules which were treated again. And then around the back, more nodules that were treated. She had a lot of pain. This is probably one of our patients who had the most pain, partially controlled gabapentin. Unfortunately, we were planning to do more ECT on her, but she had more symptoms and developed pleural metastases, so she's back on chemotherapy, but apparently there's no more progression of her skin mets. Case 5, 77, bilateral disease, estrogen receptor positive, had adjuvant treatment, had skin recurrence on the chest wall, had 1 lot of ECT. She died about 6 months later. So again, nodules on the left, pre-procedure, and 2 weeks, and there's that characteristic E-shell that we've seen with all the photos today. She had minimal pain herself. So case 6, 87-year-old, had surgery and developed an axillary recurrence, had adjuvant treatment and developed skin metastases. I had 2 lots of ECT. So more or less most of the right breast is taken up by skin involvement, more nodules in the upper part than the lower. The photo on the left shows post-procedure the first go. So she still had a lot of erythema and some E-shell, and that's the second lot on the right. This patient wasn't as much symptomatic from her ECT site, it was more from the lymphedema she had in her arm. A very frail patient, and she was discharged for palliation at home. So the latter 2 cases, probably more, the more recent cases we've seen have been probably the more advanced disease. So this is an 88-year-old who was put on primary endocrine therapy initially for bilateral operable breast cancers, and had kind of outlasted the efficacy of primary endocrine therapy, and basic disease was completely uncontrolled in both breasts. So photo on the left is supine, so both breasts are completely taken up with tumour, with skin involvement in the lower inner quadrants of both breasts and all over the breast and onto the abdomen. The photo on the right is intraoperatively, so what Tanny decides to do is just to almost debulk, to scrape off a lot of that dry stuff, a lot of that kind of bulky stuff in the lower inner quadrant, and then deliver the ECT through like an open wound. Due to concerns that maybe it might not penetrate enough, considering also the underlying disease in the breasts. Very frail patient anyway, and unfortunately had a stroke, was admitted to a neighbouring hospital, was discharged, was seen in the clinic. The wounds are okay. She very much herself thought it was worth doing something about it, even though you can argue what benefit is there from that. But she felt it was worth it, so I think that's a reasonable thing. And she actually died the day after we saw her in the clinic, I think. Is that right? Yeah. Yeah, so a frail patient. The last case that was done in December, 50-year-old lady had breast conserving surgery in May 2013, adjuvant treatment. Weekly estrogen receptor positive. She had a recurrence which is actually triple negative. She was given further chemotherapy. She started developing skin mets in April 2016, and then by November 2016 she had quite significant florid disease to the left breast. So photo on the left is pre-procedure. This is a laser.
Yes.
Yeah. Oh yeah. So she had, most of her symptoms were along what was the inframammary fold. And her major problem was that she couldn't pick up her son or cuddle her kids because she had kids at home. And she was not a happy lady, had lots of problems in the past. And so we offered her ECT, but we actually, this is post-operatively, but intraoperatively we actually again kind of almost debulked this area here. So it took off a lot of that kind of exophytic tumour there and then delivered the ECT through it. So that pain that she was describing before, she said went almost in entirety, that kind of indrawing at the inframammary fold. And she felt so much better for having done it, even with that extensive disease, with a poor prognosis, because she had distant disease also. And she felt it was a worthwhile experience. So for us, really, we've only had eight patients, so 12 episodes, so it's not much compared to some series, obviously. Follow-up is really variable. Obviously, it just depends on what adjuvant treatment they're having, etc. We haven't really been assessing quality of life. It's very much kind of almost make it up as we go along, learn by case. As mentioned before, this is all done on Tanny's hospital iPad, so that's why photos of varying quality. So what we're learning is we're still learning. Some referrals that have come through actually just isolated small nodules, actually more suitable for excisions. They've just been excised primarily rather than having an ECT given. Obviously, I think there's concerns in Gateshead that we're getting a lot of more recently extensive disease referred, and that should we be treating this? But actually seeing from the presentations today, that's quite reassuring that there are quite extensive diseases being treated with ECT. And I'm not just saying it because they're here, but Tanny would want me to mention at the bottom, because they haven't been mentioned today actually, support of the breast care nurses in kind of following these patients up with wounds, with regards to the wounds, help us in helping the patients manage their expectations, because they're the first port of call, not us. So I don't know how this compares with other units, but the wounds are managed weekly in-house by our team, so it's not district nursed or anything like that. And that's probably the last thing to mention. So that's the case for next Thursday. This is actually worse now. She was seen on Monday in clinic, and it's a lot worse around her back. So she's mostly symptomatic from her neck. It's almost like a collar of skin involvement around her neck, so that's going to be the first area to be treated intravenously this time. That's it.
Thank you very much. That's a very interesting presentation on your early experiences. Any questions from the audience?
Have you seen that extensive pigmentation that was described in some of the earlier?
Not to the same degree. There's some pigmentation, but not quite the same kind of darkness, as it were.
I was struck with seeing that on that couple of whose presentation it was early on today, but I haven't seen it on subsequent presentations. And I just wondered what the general view was. And
I wonder if the probe is different, because the marks, you can certainly tell by the little scarring.
yeah,
Because some of the probes are, the cluster of the needles are quite different. So I wonder if the probe that Dr. used was different to what we're
Trying
doing.
to have changed it for the last
Yeah.
three, 4 patients, a
Mm.
little bit more aggressive.
She uses the hexagonal probe, yeah.
Yeah, so I wonder if that's got an impact
So
on
the hexagonal definitely has a propensity to lead to hyperpigmentation.
but I remember from my days of treating germ cell tumours that you get generalised pigmentation with systemic bleomycin, don't you?
Yes.
But this seems to be much more.
Yeah, so you get, when you use it systemically for germ cell tumors,
The germ
for
cell
example,
tumours, yeah.
you get it typically in the skin because you're missing bleomycin hyperlates in the skin so it doesn't get broken down. And then typically they get like stretch marks
Yes, exactly.
So, or something on the elbow.
Pressure
so,
areas, yeah.
Yeah, so it essentially it's the same phenomenon with the needles, that you have a physical impact on the skin, and this physical impact is larger with the hexagonal than with the linear.
Okay.
Because the voltage on the hexagonal is twice of that of the linear.
Right.
So we are recommending when you are treating in place to use the linear arrangement.
So that extent of pigmentation and scarring was quite disfiguring, wasn't it, in some of those early ones we saw?
I think compared to the metastatic disease, though,
Oh,
to
yeah,
the, to the
absolutely.
patients, that's scarring healing rather than active disease.
Sure.
And I've only seen a few ladies, but I think it's a lot of, any scar that's there with disease gone, it's a lot better to cope with an active disease,
All
so
right.
to say.
Well, it is right under their nose as well, isn't it? This fungating
Yeah.
stuff.
Yeah.
Well, can I just ask what you feel that the greatest challenge has been in introducing this as a new service?
To be honest, I don't know how. I don't really know. Yeah, I don't. You,
Funding.
yeah, probably better answer that.
Took about
Yeah.
2 years, I think. In fact, Matt would probably know better. Poor Matt came up and down several times, and all clinicians were up for it. Matt was there with support. It was them trying to prove to the money givers that we needed the money. And then once they agreed, then it was going through all the process of the documentation and just passing a leaflet would take 6 months. Everything just, and you had all these patients waiting to benefit. So now it's there, I think, and now more and more people know of it. Like Rebecca is a colleague from Northumberland. She wasn't aware as soon as she heard we've had 2 of our patients. So hopefully the service will pick up, and now we know to treat early as well as treat the big stuff. But hopefully, increase the resident experience and things. But yeah, money and time, I think. And actually, as well, the theatre's training. Theatre staff, Matt was brilliant, and the company came up. And things like how to dispose of the chemotherapy. So I didn't start doing, all IV sets and things that me not being a chemotherapy theatre nurse would have thought about. So I had all that input and support.
Who prescribes the bleomycin?
Now, Mrs. Fazikan, she had to do extended prescription or something. Whereas the first one, it was the oncologist.
Yeah, a lot of places will run a sort of limited indication chemotherapy prescribing register for things like yes, that's the word I was looking for, thank you. Intracycle treatments and other localised treatments that are done outside of the standard oncology area. But it does take a lot of training to ensure the protocols are followed and that the disposal is appropriate to the drugs being used. Thank you very much, that's very good.